My name is Holly Kuzmich. I am currently a senior advisor at the Bush Institute and a managing director at the Draper Richards Kaplan Foundation. But up until last October, when David Kramer so ably filled my shoes, I was the executive director of the Bush Institute. So I'm thrilled to be here today, be with our last panel of the day. With all due respect to our previous speakers, I think we've saved the best for last. And we also know that we're standing between this crowd and lunch, so we are going to provide, we hope, an insightful and informative discussion today. Let me briefly introduce the panelists who've joined me on stage here today. Dr. Izukanji Sikazwe, who's the CEO for the Center for Infectious Disease Research in Zambia, or CIDRZ, as we all affectionately know it. Alan Maleche, the Executive Director of the Kenya Legal and Ethical Issues Network on HIV and AIDS. Dr. Wafa El-Sadr, the founder and director of ICAP at Columbia University. And Dr. Favorit Iradikunda, the assistant professor at the Elaine Mareb University of Massachusetts College of Nursing. Thank you all for joining me today. Dr. Sikazwe, Zuzu, as you've told me to call you, you earned your medical degree a year before PEPFAR came into existence. So you've really been able to see what's happened over the past 20 years. Can you talk about what changes you've seen as a clinician, particularly more broadly in healthcare and medical training, beyond just what you've seen in terms of addressing HIV and AIDS?
Okay, Holly, so I'll start from a personal perspective. And I can tell you, my dream of being a medical doctor was very different from the reality of being on the medical floors. So I went to medical school and graduated just at the height of the epidemic in my country, Zambia. And I can tell you the despair and dread that I would feel walking into the medical floors, having no real solution for the patients that we're seeing. The health system was not able to take care of these patients, given that we had no availability of life-saving medications, even though those medications were available elsewhere. In my country, it was either you were infected with HIV or you were affected with HIV. And to the extent that our former president's son died of HIV, so you can imagine the despair and hopelessness that we felt. On a professional level, I recall getting a needle stick injury. I wasn't wearing gloves because we didn't have the luxury of having gloves for routine procedures such as putting up an IV line. So finished putting up the IV line, prayed, and washed my hands. But today, I could get a needle stick injury, and I know I have more than just a prayer to hang on to. I can get preventive therapy through prophylaxis. So from having 2 centers across the entire country making available ART to having more than 3,000 centers in the public health space is amazing. I recall in 2006, after finishing my residency here in the United States and going back home to set up HIV clinics, seeing a mother and her a small child about 4 years old. I took care of them that morning. And later on in the evening, as we were driving into the next town, saw them walking on the highway. They had walked more than 40 kilometers to get to the ART center that we were providing services at. Now services are decentralized, and you can get ART within a 5-kilometer radius. Back then we gave medications for 2 weeks or 4 weeks and expected our patients to come back for refills. Now you can get your medications for 6 months. You don't have to come back to the ART center for 6 months. So changes in the health system have really been broad. There's been a lot of decentralization.
Yeah. So I'll come back to you later about some of the broader effects it's had, but Alan, I want to turn to you for a little bit of a different perspective, because the work you've done has really been about legal reform and creating the conditions for better treatment on the ground. Talk a little bit about that role of legal reform in the HIV/AIDS response.
Great, thanks for having me. I think it's very timely, and I think I need to be invited more for PEPFAR related meetings, because the last time I was invited, the High Court ruled that it is wrong to sterilize women because they are HIV positive. And today, this morning, the Supreme Court of Kenya has made a very significant decision that will help me answer the question so easily. The court ruled after 10 years of litigation that the National Gay and Lesbian Human Rights Commission can actually be allowed to register as a non-governmental organization. You're all clapping and you haven't had the fun part yet. The fun part is important because they then said that, the sort of second fun part, they said that they have a right to freedom of association, and so they're allowed to register. Freedom of association would be the equivalent of your First Amendment. Having spent time at Georgetown Law School, I have to make those comparisons. But the most and critical thing that will excite you, though we have a law in Kenya that says same-sex relationships are not allowed, the court ruled that the word sex in the Kenyan Constitution should be and must be interpreted to mean sexual orientation, and you cannot discriminate someone on the basis of their sexual orientation. So that's the fun part. So what does that mean? So someone will think this is just all legal stuff and Alan loves to litigate, but this is what it means for HIV. You work with groups that are criminalized or marginalized and are unable to register. For you to get funding from any donor, they need to see some form of registration. This now means the community-based groups of people who live with HIV, of gay communities, can easily register as a non-governmental organization and be eligible to get funding, be eligible to advocate for issues within the parameters of the Constitution, and that's how exactly the law has been working for us. Now, it's not always joy and success as you see it. There are challenges. The same Kenyan, the High Court a few weeks ago, a case in which I've been involved with, supported with Global Fund money, we sought to try and get off the books a law that says if you do anything that puts another person at risk, you've infected them with HIV. But in that case, the court did not agree with us, and we're going to appeal the decision with the hope of success. So I think the take-home point here is we must appreciate that much as we started the HIV response from a biomedical perspective, we need to make investments to address the structural and legal barriers, because if you don't address those, then the pill will not get to the young person. It will not get to the sex worker. It will not get to the mother living with HIV because of the stigma and discrimination that surrounds it. So unless you remove those barriers, which UNAID has rightfully told us, if you do not address those barriers, you will not meet your targets, and we will not be celebrating 2030 to say we have finally won the fight against HIV. So that is why the law matters. And for those of you who believe in scholarly articles and writings, look for the Global Commission on HIV and the Law report. It actually documents this. It was a joint job by UNDP and UNAIDS. And actually many of the recommendations it gave are actually coming into life in terms of when you change the legal framework, when you change the policy framework, you then have better results in your HIV response.
Thank you. Dr. Al-Sadr, the work that ICAP does is so fundamental to addressing this issue. You're responsible for those population-based HIV impact assessments, the PHIAs, that bring so much data to everybody working at the government level, on the ground level, on HIV/AIDS. But that data also includes information on other socioeconomic factors. So how has that really sort of not only affected HIV/AIDS, but how has that brought to light some of the other important indicators that we need to pay attention to and some of the follow-on work that has happened?
Sure, thank you. And I think what we've heard today thus far has been quite instructive, and it just in reflecting on the reasons for the success of PEPFAR have been many, and some of them in leadership and partnerships, and I think also, of course, community engagement and legal engagement, but I think very fundamentally it's been demonstrating results. And I think that's what's has motivated this very important bipartisan support. And what that means is having the data available. And I have to say that the PHIA surveys have been very important. These are surveys that are led by the ministries of health in the countries where the surveys are done. And they involve a huge community mobilization across these nations. It's truly a national commitment to try to figure out what's happening in terms of HIV within the country, and then to take the data, and as the Minister of Health from Eswatini has said, to really focus on the cascade of data, not just to get the data, but to look at the data and examine the data and use it to tailor with precision what we do moving forward. So I think that's been a remarkable achievement of the many countries around the world, but also of PEPFAR. And importantly also to measure over time, as has been done in Eswatini. We need to measure to see whether the gains are sustained and where the gaps are, and modify the programs. But I think it's often not appreciated that these surveys not only measure HIV metrics, but they also measure other metrics. They measure sociodemographic characteristics, for example. They look at food insecurity, which is very, very important. They look at issues around gender-based violence, issues around migration, stigma, and so on. And these kinds of data help, again, the countries themselves and the ministries and national HIV programs to be able to look at where the gaps are and use these other data to try to address these gaps through addressing some of these structural issues, whether it's food insecurity or the legal environment. So you identify the gaps and use other data and all the assets in the country to try to figure out how to overcome these gaps. And I think that's why there's a breadth of information that's available out there that can help us to maintain the gains, but also to address the gaps that still remain.
Yeah. And can you add a little bit more as well on where you've seen that data inform some new work that we've done and where we still have so much room to go?
I think an example has been looking at young women. We talked about girls and young women and their particular susceptibility to HIV and inability to access HIV and to overcome stigma. So some of the data around the stigma, for example, the data around use of health facilities have motivated, for example, having programs like the DREAMS program that is targeted to young women and to girls. And that's a way of trying to help these young women, help these girls to overcome some of the enormous structural impediments that they face day in, day out. So I think the data, the biomedical data, as well as the social data, as well as the economic data that are collected and need to be collected and further expanded, are the kinds of data that can help us shape the programs to be able to address the gaps that are still there.
Yep, great. Favourite, I want to turn to you. You've really spent your career working on maternal health. And we know that there's a relationship between PEPFAR support and investments and improvements in maternal and child health. Help illuminate that connection and what's behind that and what you've seen.
Thank you for that question. And I am going to start by saying that I began my nursing training just 3 years after PEPFAR was established. Don't do the math. And one of the things I've been thinking about for the last few weeks was just really thinking about the healthcare providers, nurses and other healthcare providers who were there, who were caring for their families and communities, not having access to treatment, not having any hope of being able to heal their communities, but they persisted and they advocated. And one thing I want to say to them today, we have some of them here, is thank you. And I share that to say that I am so grateful to have become a healthcare provider at a time when PEPFAR was there in my country, and not having to go through that moral agony of, I'm caring for communities, but I don't have access to treatment, or they don't have access to treatment. But the journey is we are still on the journey, and I long for a day when we'll come back here or somewhere else to celebrate the end of HIV/AIDS. I hope we throw a really big party, because I love parties, to mark the end of this disease. But back to your question about maternal health. Yes, it is true that we have seen some spillover effect. It's been defined as a spillover effect, where we see that PEPFAR investments in PEPFAR countries have had positive impact on maternal health outcomes. And some of the indicators we have seen improve is maternal mortality in PEPFAR countries has declined. We have seen a decline in infant infant mortality as well, and we have seen a decline in anemia in reproductive age women, and we have seen that as a result of investment, as it's been mentioned earlier, in the healthcare workforce, investment in nurses and other healthcare workforce, making sure that they are trained, making sure that they have access to resources to be able to care for women and children. But again, even there, the journey is still long, and we need to continue investing because maternal mortality is still very high in sub-Saharan Africa. Honestly, the rate is not acceptable, and so we need to do better in investing. Every mother deserves to have a healthy, safe, joyful pregnancy, and so we need to continue investing in that, and every child deserves to have a joyful, healthy childhood, and so this is why we need to keep investing through PEPFAR and other organizations.
Yeah. Also, speak a little bit to the role of nurses. We've talked a lot today about the large variety of people who've been so instrumental in the implementation of PEPFAR. Talk about that role of nurses.
So nurses in PEPFAR countries, but also globally, they constitute a large number of the healthcare workforce. And nurses are everywhere. They are at health posts. We've talked about health posts. They are at healthcare center, district hospitals, referral hospitals. Nurses are everywhere. Nurses also have special relationships with families and communities because they spend a lot of hours. They do a lot of education. They do education in the community. They do education at the hospital level. And so they have played a major role in making sure that communities are informed, making sure that communities have access to the resources. They've played a major role in advocating, and nurses were there working with the community from the very beginning, and nurses will be there to take us to the end of this pandemic.
Are there things we can do better to support the tens of thousands of nurses out there doing this work every day?
Yes. How many hours do we have?
17 minutes. 17 minutes.
Yeah, and so one of the things we can do is currently we have a huge nursing shortage. Different countries have different levels of that shortage, and it's affecting the healthcare system. And so we need to invest in nursing education. We need to make sure that nurses have access, or people who want to pursue nursing have access to education. And nursing education is not cheap in a lot of countries, and so we need to make sure that, again, we make it possible for people to attend nursing school. When they go to school, they need people to train them, and so we also need to invest in nursing education and making sure that the working conditions for nurses are good. And so we need to make sure that they are being paid fair wages and that they are being treated with justice, and they're being treated fairly and being compensated for the work, the amazing work that they do. That's just a summary of so many things. I could spend a day.
Great. Yeah. Thank you for sharing that. And Zuzu, I want to go back to you and talk a little bit about COVID-19 and how we've seen the infrastructure and the systems of PEPFAR have a role in addressing what we've seen on the ground over the past 3 years. Can you share a little bit about what's been happening?
Yeah, sure. And before I come to that, just talking about nurses, one thing that we've seen is that there's been a lot of tasks shifting to the nurses. It's almost like getting dumped on with the different strategies and initiatives that are coming in through the different programming. So lots more investment is needed to make sure that the nurses are capacitated to be able to deliver on the care that patients are looking for. Coming to COVID-19 and some of the infrastructure that has been beneficial in my country at least, and I'm sure across the region, is that the infrastructure that we used for the HIV programming was able to be used as a springboard for other activities. If we take patient care, for instance, we're able to decentralize patient ART delivery services and keep those patients safe. At the same time, we use that mechanism to provide under 5 clinic support to mothers and their children, so they didn't have to come into the health facilities. We're able to decentralize and support antenatal care. Importantly is some of the work that was done around the laboratory strengthening over the last 20 years. In my country, laboratory services were initially very centralized with hub and spoke models, but over the last 20 years, more and more centers have been built across the country. And that infrastructure, especially what we use for viral load testing, was used for the initial PCR testing for COVID-19. We use the same mechanism for sample transportation. So sample transportation that was used for viral load testing, early infant diagnosis, was also used for transporting COVID-19 samples across the country. So we're able to piggyback onto the infrastructure that had been built with PEPFAR funding.
Yeah, great, thank you. Alan, I want to come back to this issue of human rights and democratic principles and the role of PEPFAR in that. Talk a little bit about the role of some of these activists on the ground and how you've seen that play out.
So the role of PEPFAR, human rights and democracy, I must be honest, is a mixed bag. A mixed bag in the sense that having approached our HIV pandemic from a medical response, there was little investment in looking at what does this mean for the actual person as a holistic human being. But with time, there have been improvements because people are open to feedback. People have seen the importance of why it's not only right to base responses on human rights, but also it's efficient because it actually helps you get results. And so what we have seen is PEPFAR opening up a space through various processes and programs that allowed for human rights and democracy to happen. So some things are taken for granted, but let me use the example of the country operational plan process that is going to be happening in Johannesburg. That particular process brings everyone on the table, whether you're government, whether you're civil society, whether you're a doctor, and that's how democracy works. You've got everyone on the table raising their issue, raising their voice, and that's opening a space because there are many countries across the globe, and not only in the global south, where that space is not available. So that happens. And whoever moved the COP from DC to Johannesburg, again, decolonization, just throwing in the buzzword, shows that you're bringing it closer to the people and being cognizant of the fact that you're coming to a central space. So that's one way to look at how PEPFAR is driving that particular conversation on democracy and human rights. But more importantly, Kerlin, having been a recipient of the DREAMS initiative, and I'm hoping it's not the last time we are receiving it, we were able to work with different stakeholders in the community, lawmakers, judicial officers, young women, chiefs, religious leaders, and getting those people to have conversations beyond, yes, this is the science of HIV, but what are the practices that are affecting our young girls from being able to safeguard their rights to access healthcare services? Those conversations were very critical in terms of creating an environment. And so I am a big champion of the DREAMS program, not because Kerlin got money, but because I have witnessed some of the results that it has had in terms of changing the shift in conversation, whether it's cultural conversations, whether it's power imbalances, whether it's driving law reforms. I think there's room for PEPFAR to be able to step up on this so that we can then be able to get the results that we want to get in 2030 of bringing an end to the HIV epidemic.
Yeah, thank you. Wafa, you talked about the data that is collected. What are we not collecting that we should be?
I think I can think of a lot of different ways of answering this question. We've heard today, all day, about the investments by PEPFAR and in a variety of different domains, in terms of the health system strengthening overall, in terms of the investments in terms of in terms of the governance and the governance of the health system, in terms of also the platforms that have been established, in terms of the investments in not just medical programs, but also in social programs and support programs. Some of them were mentioned by you. And I think it would be wonderful to, while we have some data on those, I think it would be great to be able to demonstrate beyond the, I know what the answer is going to be, but I want to see the data to demonstrate beyond a shadow of doubt how much all of these spillover effects, the direct and indirect effects, all of how, the impact in terms of the data on these metrics, whether they be in terms of things like life expectancy, for example, that's one important measure, but also the economic impact in the countries themselves, the change in the laws and legal environment in the countries where PEPFAR has worked, the impact in terms of other diseases, for example, the use of the platform to impact on maternal health, child health, non-communicable diseases, the laboratory investments, what they have meant in terms of diagnosis of anemia and so on. So I think there are a variety of different biomedical, but also beyond that, economic and social metrics that I think can be gathered and also can be very helpful as well moving forward. And I think that these metrics can also not only be useful in and of themselves, but they also can, again, pinpoint to us where the gaps exist and what we can do to address those gaps.
This is, Favorite, I'm going to direct this at you, but anybody on this panel, please feel free to weigh in. You were with us at the Bush Institute 5 years ago, and you talked about collaboration that you were seeing on the ground that was starting to move in a better direction. I'm interested to know how you would assess the level of collaboration that's happening now and where we still have room to improve and who's not at the table that should be.
Thank you. The collaboration is much better in my assessment. And I think I've seen more of an interdisciplinary approach. And so I've seen teams take an interdisciplinary approach. And as Bridget mentioned earlier, when we're talking about innovation, we talked about the different needs to meet, different population preferences and needs. And so we are doing better at bringing in other people who are not necessarily healthcare providers. We're doing a better job of collaborating with different people from different fields. And so moving forward, I think that's something we need to harness. We need computer scientists. We need engineers. We need, for different things. And so we need to make sure that we are approaching this with that interdisciplinary approach. Another aspect of that collaboration is collaboration with communities and making sure that we are centering community voices, making sure that we are centering their, because they are thinking through these issues as well. It's not like this community that's sitting somewhere, waiting for someone to come and do something. And so listening to their perspective, listening to their voices, and making them equal partners. I think we can do better, and we have, but making sure that they really are treated as equal partner. Another last aspect of this collaboration that I actually want to talk about is, this is my second time here. Last time and today I learned so many things from leaders who have been here from the very beginning. Some of these things are not written anywhere, and so you can't read them. And so as a young leader, I'm like, where do I get these? We need mentorship. And so I think part of this collaboration is making sure that leaders who have been fighting the fight are mentoring young leaders and really helping them to get to know what they have done, what could be improved, so that we make sure that we are passing the baton, because it's, the emerging leaders now are the leaders of today. They are the leaders of tomorrow. They are, I believe, the ones who are going to take us beyond AIDS.
That's a great point. That's a great point. Alan, and we'll go down the line.
Okay, I guess the example that comes to mind for me is a practice and a program that has been catching a lot of pace on community-led monitoring. I'd like to look at it as a way where collaboration with PEPFAR is working with the communities, where you invest money in the communities to follow what has been funded, not only by PEPFAR, but also their national governments, because I highly believe that where I pay taxes, someone should be responsible for my health, and it's not always PEPFAR to fix it. And so they are playing the dual role of ensuring the dollar PEPFAR puts in is actually doing the right thing, but also what the government is investing is doing the right thing. And by doing so, they're not only concerned about health outcomes, they're concerned about governance processes. And with that collaboration, you're helping people living with HIV or those who are receiving services to be more participatory in their democratic processes. It doesn't mean they're going to vote, but they're in forums and sessions questioning, PEPFAR send this money, I don't see the clinic, I don't see the condoms, I don't see the lubricants. They are documenting it, they're collecting data. I know Dave is crazy about data. They're collecting data, and they're using that data as evidence to advocate. So they're not giving sob stories, they're actually coming with actual evidence. And so there's need now for PEPFAR to step a notch higher to scale this up. And I think I want to sort of say this as I conclude, because time is out. You must look at it this way: the job is not done. PEPFAR is the only thing standing between good services that are dignified and people backsliding back to human rights violations and new infections. So you must realize that the work is not done. We are celebrating. I don't want to dampen the spirit, but the work still has to be done. And for that work to be done, we must invest in reaching the hardest to serve and planning on a responsible transition. And where you realize you cannot responsibly transit, stay in and provide the services till the time is ready. So that's the additional put in.
Certainly the work is not done, thank you. And I think we've come a long way, but I think we have still a long way to go. And I think we have a lot to learn from what we already have accomplished, and I think we have to use those lessons well as we move forward. And like I said, we have to sustain the gains. It's very important to sustain the gains, as well as to also reach the gaps and be able to fill those gaps as we move forward. In terms of, I do feel that it's important for maybe people in the audience who are not out there seeing this work, is that the PEPFAR supported programs are owned by the countries themselves. I mean, it's their program. They own these programs. They run these programs. They're very proud of these programs. They work so hard to get us to where we're at, and I think we have to acknowledge that. It's the work on the ground that has enabled the lives saved, and PEPFAR has facilitated, motivated, enabled it. But it's the people on the ground that have worked so hard for their own communities and their own people. I think also one other message is there's so much of South-to-South learning that can happen. There's such a richness of knowledge and innovation that exists, and facilitating this kind of South-to-South learning. We, at ICAP, we have the Sequin network, which is focused on differentiated service delivery. But what I've seen is how learning networks that South-to-South learn, where ministries can come together and learn from each other. It's remarkable, because they know what's worked and they know what's not going to work, and they're so eager to and so generous with sharing the knowledge, and they're so honest about what's worked and what hasn't worked. And we have so much to gain by enabling that kind of learning and cross-country learning.
Yeah. So I think picking up from Wafa's point, my group has been referred to in the past as a PEPFAR baby because we're a local NGO, but this baby has grown, is a permanent resource to our government. We implement really, really good programs with PEPFAR funding. We influence national policy as well as normative guidelines from WHO. So I think, PEPFAR has invested a lot in localization of the response, has invested in local NGOs and has grown their capacity. And I think it's in recognition of the immense human resource and technical expertise that is available on the African continent. And I think in terms of partnerships and collaborations, as we move towards the next 10 years or getting to 2030 and thinking around who is it that we're leaving behind? What is the dialogue that we're having? You know, I've been hearing more around long-acting injectables and how they're costly, may not be implementable in our setting. Africans may not accept to be having this injection every 2 months, so on and so forth. It reminds me of the conversations that we had at the start of PEPFAR. You know, Africans won't take their medicines on time, they won't adhere to the regimens, on and on and on. So we have new toolkits, new tools in our toolbox. Can we get rid of the old dialogue and think more positively and act more proactively to be able to take on those new tools that we have to work with to prevent new infections, to do away with the inequalities and really work towards ending the epidemic?
And I am confident that Africa will again prove the naysayers wrong. I am confident of this.
Always.
Yeah, that's right.
Absolutely.
Well, thank you all for both highlighting the progress we've made and the work we have to do, because one of our messages today is we've got to continue at this. So thank you all. Please join me in thanking our panel.
And let me, before we wrap up, let me just say a big thanks to Holly, because actually this event was her idea. And I was incredibly fortunate for her to hand off an amazing team to me to help bring it across the finish line. So Holly, thank you very, very much. We're a little uncharacteristically behind schedule, and for those of you who know Bush World, if you're on time, you're late. So I'm going to keep this very brief in wrapping up. I do want to thank the U.S. Institute of Peace for giving us this amazing space for today's event. My thanks to them, Bank of America, Gates Foundation, and FlexJet as well. In summing up, PEPFAR is a true public-private partnership. It is a program that gives hope, creates opportunity, fosters stability and prosperity, and renews faith, as well as paving the way for a better and brighter future. We've heard the numbers today, but a lot of people in this room, a lot of people up here, are the human faces of those who have either benefited or have provided the benefits. And so to all of you, I want to say thank you very, very much for being with us here today. Those of you watching on live stream, thanks for joining us. And those of you here in the auditorium, we are going to go right out here to lunch. We do feed people here in the Bush World, and it's a nice lunch, so look forward to having you there. Thank you all very, very much.